Good afternoon, Excellencies, distinguished guests, friends and colleagues joining us here in person in Geneva and also online from around the world. A very warm welcome. My name is Suri Moon. I'm a professor here at the Geneva Graduate Institute, where I also co-direct the Global Health Center. It's my great honor to open today's session on behalf of all of our partners, whom I would like to thank for their fruitful collaboration, preparing for today's discussions, the World Health Organization, the European Commission's Directorate-General for Health Emergency Preparedness and Response Authority, the German Federal Ministry for Economic Cooperation and Development, the Ministry of Health of the Republic of Indonesia, and of course the International Geneva Global Health Platform here at our center. Thank you for joining us today to discuss an issue that remains one of the most important, but always one of the most politically difficult: how to ensure equitable access to vaccines, therapeutics, diagnostics, and other life-saving tools for health emergencies. These are usually the very last issues that get resolved in political negotiations. We saw this during the international health regulations, and again now with the pandemic agreement, as we see with the PABS Annex. We all know that countries have not yet reached consensus, but from what I've been hearing all week, it's clear that this has to get done. Our center has been supporting these negotiations for the last 5 years through our Governing Pandemics initiative, and based on our observations and conversations, I would say I'm actually optimistic. Perhaps this is not a universally held view, but I'm confident that it can get done by the next WHA. There's been a lot of attention to the PABS Annex, and that's natural, but today we actually want to take a step back. We want to widen the lens and take a look at the broader medical countermeasure ecosystem. We can think of the IHR and the pandemic agreement as the laws of nature in a way that govern this ecosystem, like gravity or entropy, perhaps. But ecosystems, of course, don't only have laws of nature. They also have water, they have air, they have plants, they have soil. And we're going to hear from the water and the air and the plants and the soil in just a few minutes today. But I think the key question we want to ask in today's discussion is the medical countermeasures ecosystem that we have today healthy? Can it protect all of us and protect all of us equitably from the threat of outbreaks? Does the combination of water and air and plants and soil produce fruit? And by fruit, I mean, of course, the diagnostics and therapeutics and vaccines that we need. Who gets to eat the fruit? Who gets to eat the fruit first? Is there enough fruit for everyone to enjoy? Tough questions. The Ebola Bundibugyo emergency and the hantavirus outbreak are, of course, a reminder that nature does not wait for humans to finish treaty negotiations. And we have already on our hands today a test of this ecosystem. As many of you are very aware, neither the Ebola Bundibugyo virus nor hantavirus have proven vaccines or therapeutics. And we were just reminded very strongly that the diagnostics available in Ituri province were not adequate to detect the Ebola outbreak early enough. So this discussion could not be timelier. To set the stage, we will first hear from Dr. Chikwe Iyekweazu, Executive Director of the Health Emergencies Program at WHO.
Colleagues, thank you for joining us today, and I'm sorry I cannot join you in person. Firstly, I'd like to thank our co-organizers, the European Commission, the German Federal Ministry for Economic Cooperation and Development, and all our partners for bringing us together. I'd like to particularly thank the Graduate Institute for hosting us and for moderating this session. Recent health emergencies from COVID-19 to Mpox have reminded us again that equitable access to medical countermeasures is not optional. It is essential to save lives and protect the vulnerable. Yet, despite some progress, access to vaccines, therapeutics, and diagnostics remain uneven and often delayed, particularly in times of crisis. Today's discussion comes at a pivotal time for all of us, as member states advance key global processes, including the WHO Pandemic Agreement. We are collectively being called on to move from commitments to concrete implementation. This brings us to move beyond crisis-driven approaches toward a more coordinated, resilient, and end-to-end MCM ecosystem. An ecosystem that connects research and development, manufacturing, allocation, and delivery, and ensures that all countries can access the tools they need when they need them. I'm pleased to introduce our keynote speakers who will frame this important discussion from the perspectives of member states, providing complementary national and regional views. We are honored to be joined by His Excellency, the Minister of Health of Indonesia, Budi Gunadi Sadikin. His Excellency will share his political perspectives on strengthening the global medical countermeasures ecosystem and reflect on lessons learned from recent global health emergencies. We're also delighted to welcome Mrs. Florike Fink-Hoje, the Director-General of the European Commission's Health Emergency Preparedness and Response Authority. Mrs. Fink-Hoje will speak on the European perspective on investment, coordination, and equity in the medical countermeasure space, particularly in the context of fiscal pressure and competing priorities. I'd like to share my appreciation to all of our speakers and panelists for your leadership and commitment. Strong political leadership such as yours is essential for the work that we do. Without it, we cannot move forward in building a more equitable, resilient, and coordinated global system for medical countermeasures. Let me use this opportunity to move beyond rhetoric and focus on practical solutions that can deliver impact, ensuring that equitable access to life-saving tools becomes a reality for all populations. Thank you for your commitment and engagement, and I wish you a productive and forward-looking discussion. Thank you.
Thank you very much. Thank you very much. Since Dr. Chikwe has already kindly introduced our first keynote speaker, I will just say a few brief words that under Minister Budi's leadership, Indonesia has been one of the countries that is very proactively shaping this ecosystem. And I was very happy to hear Dr. Chikwe also using this language of ecosystems. I think we can say that under Minister Budi's leadership, Indonesia is one of the big trees in the ecosystem. And so I very much look forward to listening to your remarks. Please.
So, ladies and gentlemen, good afternoon. I was a scientist by training, so I'm a physicist. And then I spent 30 years in banking. And then suddenly the previous president put me into as the first health minister without medical background in Indonesia to take care of COVID. And at that time, I received a lot of budget, like all of you. But then recently, in the last 2 years, the budget keep being cut, and they move it to something else. So I talked to my fellow, the Minister of Defense, I understand why you have a lot of money, now much more money than I am. But if we are talking about history, the Minister of Defense's job is to protect the life of the citizen. Historically, if you observe war with people, the largest casualty was World War II. If you Google, 50 million people die. There is another type of war that kill more than 50 million. It's war with pathogen. If you look at the history of humankind, Black Death kills 200 million people. The Spanish flu, more than 100 million people. I just checked HIV. Now, maybe 40, 50 million people, the same as World War II. But World War II is stopped. HIV is still going. Tuberculosis, we had several meetings tuberculosis. 1 billion people until now. So my, nice discussion with my friends, the Minister of Defense, which has now become the President of Republic of Indonesia, is why we have to spend so much money in creating the radar systems, which you call a surveillance system for defense, but I only get 10% of it for surveillance in healthcare. Why we spend so much money billions of US dollars to create weaponry, missiles, guns, rockets, drone. But we spend only 10% of it to establish weaponry system advance in healthcare, vaccine, therapeutics, pills, long-term injections. And that is scientifically is wrong because why? Because you only kill 50 million people historically. You know, my field kills 200 million people and going on. So we should get more money. And I still fail to convince them. So I do hope my colleague from European Commission can convince the leaders, political leaders, better than I do. So that is the first thing that I would like to share with you, that this sector, you know, kills more people in our history. So we need to put more resources in it. So the second things, and I will close to the third things, which is I'm very passionate about the pandemic treaty because I'm part of it. And the second topic is when we want to build the what they call it a resilient system, the medical countermeasures. As a scientist, my curiosity is high by nature. So I said, oh, we have to do a good surveillance system. And at that time, I just realized that Indonesia only have maybe 20 PCR machines back in 2020 when I came. And we did 200 genome sequence of the virus on the last 9 months, which is, I don't understand what is genome sequence, what is the variant, what is DNA, what is RNA, because I came from physics. But when I compared to Singapore, they did 5,000 sequence. We did 200 sequence. Singapore is only 5 million population. We are 280 million population. Something logically wrong here. So we don't have the surveillance system. So that is something that we improve. Now we have PCR machine in 514 cities. And I just learned that PCR is like a microbiological testing, and technology is progressing. This year, Indonesia just make a decision to buy 4,000, the NPOCT we call it, point of care terminal, basically a small PCR machines that you can have the cartridge. Each of them, the price is around 1,500 US, can be operated with battery, and each test can only cost you 3 US or below 3 US dollar, and they can test pathogen. 5 pathogens are already available. We will deploy 4,000 this year, 6,000 next year, so 10,000 radar system. Instead of expensive radar system to detect drones and missile, I will have 10,000 radar system in 10,000 primary healthcare clinics owned by the government in 10,000 districts, in 7,000 inhabited island, to do surveillance for 280 million Indonesians. Because we have 34 provinces, 514 cities, 10,000 districts, and 85,000 villages. So we will put this surveillance system at the district level. Theoretically, we can use these machines to go down to 85,000 villages. So then we have a very comprehensive radar system to identify if there is movement of new pathogen coming in. Now we are building capability to create the prime, the probe, the enzymes, so we can create this $2 cartridges, which is needed and depends on the type of the new pathogen. But the infrastructure is already there. So I'm quite happy, although it's much cheaper than expensive radar system or Patriot system or whatever system, the David Sling or whatever, we already have this surveillance mechanism. And we enhance with the complete real-time PCR machines at 514 cities and the genome sequencing machine at 34 provinces in the country. Thank of the help of World Bank that give me $4 billion of money in the next 3 years. So we can do it. So that is on the surveillance side. Now, on the vaccine side, because I realize, again, out of curiosity, we have therapeutics, we have diagnostic, emergency medical countermeasure, we have vaccine. But the pandemic definitely is controlled when we have the vaccine. I'm not a medical expert, but I noticed most of the pandemic, if we have the vaccine, then it will decline drastically. So I said, okay, after surveillance, I need to develop the capability to develop vaccine. Indonesia have one company, 2 billion facility, 2 billion doses, export polio vaccine to 150 countries globally, level 4 regulatory, whatever, ELA, regulatory level 4, and then, but only one company, government owned. So since 2020 until now, we add additional 3 vaccine manufacturing companies. Now we have 4. Now we have 4 companies, and the capacity total is 3.6 billion doses every year. However, this vaccine company, most of them when I joined, the CEO is sitting there, can only mostly do fill and finish. But now I asked them to push it back so they can produce drug products and then drug substance and also the seed vaccine. So research and development do seed vaccine, and then growing the seed vaccine into drug substance, formulation of drug substance become drug products, and then fill and finish until done. And it is our intention to transfer the technology across as many countries as possible. We are working with Pakistan, we are working with Ethiopia and Ghana also. We would like to do transfer of technology down to the research and development to develop seed vaccine. Because Indonesia believe, our experience during COVID, we signed a contract with somebody and then the country decided not to export the vaccine and we die. I have 280 million people to protect. So vaccine for me is not a commodity, it's not an economic perspective, but we need to see this as a resilience perspective. We need to have at least 50 countries, maybe 30 countries in the South have the manufacturing capability to produce the vaccine the same quality as we are. And we will transfer the technology down to the research and development so they can produce the vaccine in Nigeria, in Ethiopia, all in the large country, Pakistan, Bangladesh, etc. So we have, if something happens, Indonesia like a vaccine, we can ask 5 million from Pakistan, 5 million from Bangladesh, 5 million from Ethiopia, rather than concentrated our vaccine manufacturing company in only a few countries. As a banker, I never put my eggs in one basket. I would like to have as many baskets as possible. So that is on the vaccine things. That's why I put Ibu Rizka, our Director-General, to be the board of CEPI, to make sure that the 100 days vaccine will be available. I sit at the board of Gavi because I just want to make sure that I keep getting, the vaccine priority, especially the tuberculosis, because I was asked by Dr. Tedros to co-chair the TB accelerations, vaccine accelerator. And I put an Indonesian representative also at the board of Global Fund. Now, my last topic that I would like to share with you is the financing, because it's always be an issue. Ladies and gentlemen, I would like to share with you that the idea of pandemic fund and pandemic treaty happens at G20 meeting where the Italian become the president in 2021. That was the first physical G20 meeting in Italy, and everybody is wearing a mask. From 2021 until now, out of those 20 health ministers, I'm the last Mohican. I'm the only left living person who understands the debate in that meetings. The rest is gone. I met with 2 American health ministers, 3 Japanese, 3 Chinese, and to the extreme side, 8 UK health ministers, and that I only know 5 of them. Yeah, 5 of them. So I lose count already. Germany, I think I saw 3, and the rest. Yeah. But UK is the most dynamic things. The dynamics. My UK president. But this is what I would like to say to you. During crisis, all health ministers are confused about how to get the money, but not all. Yeah? Not all. The rich country, they don't look for money. But some of the middle income country, G20, how can we get money? Number 2, how we can get emergency medical countermeasure if we had money? So this is all the countries are confused. So there are 2 problems, the Minister of Health. Different with Minister of Finance. I'm a finance person. If financial crisis happens, I've seen financial crisis in 1997-98, Asian foreign exchange crisis. The Thai person is here. He is the one responsible for this one. The subprime mortgage crisis in 2008, big mortgage crisis. Merrill Lynch gone, Lehman Brothers gone, so many U.S. banks gone. The European bond crisis in 2012. I've seen all of them. I wish I haven't seen any financial crisis in healthcare sector. Suddenly I moved as health minister, we had a financial crisis in healthcare sector. But I would like to share with you, I'm sorry, I have to do it quickly, I will close like this. We need to have an institutions like the World Bank and IMF, that global leaders sit together in Bretton Woods in 1944. World Bank and IMF. So they helping the global financial crisis and protect the world. So that's why two ideas came out, the pandemic fund and the pandemic treaty. Pandemic fund to provide the money. Pandemic treaty, it is as simple as, during crisis, we need to make this as a public goods. That is the essence. The PAPs, the everything, but the essence during the health minister meeting, Jati, we have to create this is a public goods, emergency medical counter. Because you cannot play God who will live. During the discussion of pandemic fund, Indonesia managed to make it done in 1 year. The pandemic treaty extended. And I feel very, very sad as the only health minister left. If it is going, it's not closed, and you lose the substance because you are heavily discussed on the word legal terms. I understand that, you know, the industrialists, we need return, but that is the job of pandemic fund. The Pfizer, Moderna, they don't put any capital at risk. That is the Operation Warp Speed, the US government give money. So they are not actually should complain that I don't have any, I put my risk there. No, it's the government that do it. Pandemic fund are equipped to do that. So the money will be there. I understand they need to have a return. Yes, the pandemic fund can guarantee the return, but not excessive. Not excessive. There is a Gavi that can do market shaping and pool procurement to make sure that you get money, your return back. But you have to charge the US, richer country, you know, the 50% margin, the African is less. So, ladies and gentlemen, please, the pandemic fund and the pandemic treaty is there. Make sure the pandemic treaty job is to make this emergency medical countermeasure during crisis become a public good. So everybody have the same right to live. Thank you.
Thank you so much, Minister Budi. And indeed, your comment about the importance of thinking about countermeasures as public goods, I think is a great segue to our next keynote speaker. And one of the big questions is, of course, how to make that happen. Not just that we need to make it happen, but how to make it happen. So indeed, our next keynote speaker, Dr. Florica Fink-Hoya, has also already been introduced by Dr. Chikwe. She's the Director-General of HERA. I will only say that while HERA is a relatively young institution, only 5 years old, it has quickly grown to be one of the most important elements of the ecosystem. You could call it a fast-growing species, and I hope that it will continue to do so. Please, thank you so much.
Thank you, Suri. Thank you, Suri. Thank you, and Minister Budi, we will meet in Jakarta, I think in June, and we will discuss and exchange our tactics talking to the defense ministries, and which we do as well, and also on wastewater surveillance systems, because I think that's where you're also interested. But let me start by saying, dear colleagues, dear friends, and dear Minister, thank you for being all here. I think we might not realize it, but we are in a bubble here also in the health community. So for us, we are already very much ingrained in all the medical countermeasure discussions in the ongoing crisis, Hunter crisis and hantavirus crisis and the Ebola crisis. But we might not realize that what we are now discussing and how we will take the next steps will actually shape also the world outside and how we will respond to a next crisis. And that next crisis will come. It is not just the ongoing two crises that we are now facing and many others in which are more local, but it will be important for the health architecture, how we are reacting now in these two. And I must say, I take a certain pride that Europe acted very, very quick, very transparent, and also very disciplined, and with a lot of trust among the actors, which is not obvious, on the hantavirus, which is not over, but it is contained. So now we have to look at the other one and still keep a watchful eye on the hantavirus. But what I'm wanting to say is we need to convince also the policymakers, also the budget people, that we do the right thing and that we are reliable. Because actually when we had the real big global pandemic in 2020 or 1920, we already had days, we partly had weeks to act. And we were still very slow, despite having the science in place, despite having health ministers giving warning signals, despite having other parts of laboratories who would also give the signals, but we didn't pick it up, right? Or not quick enough. We were not speeding enough because our system was really not built for that, not for speed, because we didn't have, let's say, the manufacturing in the right place that could scale up. We didn't have procurement frameworks, at least not in Europe. We didn't have the surveillance networks. We had some, but they were having gaps so big that a whole pandemic globally could walk through. And that's where I think we are in a better place now, but we also have to prove in these crises, ongoing crises, why we can be even better prepared. Because we all should remember that with COVID, it had such an impact on our societies, on our economies, on everything, on a whole education lost for children, and lives. We lost so many lives. You spoke about millions of lives. That was millions of lives as well. And that we should not make happen again, and we should not be slowing down again. But we are in a very difficult context. We are in a context where geopolitically, very fragile, finance, global finance, not really looking at health, and even worse, I would say, health has really become transactional. Health is something which is a geopolitical instrument. It's certainly not necessarily treated as a global good, and that we have to bring back. And I have to say that as European Union, we are very adamant on bringing that back. That's why we also had our Global Health Resilience Initiative coming out, and where we repeat that all the time. Preparedness is really not an afterthought. It shouldn't be, because even when we would have a sort of more military conflict, health always is part of that conflict. And the civilians will be not necessarily even the biggest casualty, but they will also have to help the other side, the military side. So it's going hand in hand. But let me say a little bit what we have today in Europe and why we think this also helps others, and why we have put it in our Global Health Resilience Initiative. Not to be patronizing, but rather to say these are models that for us were important, and we are happy to support capacity building on similar models adapted to, of course, other regions, other local circumstances, if you want. We have now, contrary to the time of COVID, we have ever warm manufacturing capacities. We call it ever EU FAB, but they are ready to scale up. And they are ready actually also now to scale up should we need therapeutics in the Ebola context. We have, for instance, also we have a whole system that we are setting up with different industries where we would know what are the capacities, what are their technologies, how would they be ready or not ready to share with others these technologies, and we call that a ramp up. In order to also make it a bit more attractive for others. We have joint procurement with 38 people, different measures. Joint procurement, which, by the way, can be used for the defense ministry as well as for the civilian side, because it's just a dual-use MCM, depending on what it is and what you would be needing. And we are now setting up global workshops on procurement everywhere, with WHO as well and other partners like POW, who have really a huge amount of experience, in order to incentivize and support, coach others who would also like to go into this type of joint procurement mechanisms and how to set it up, and also ourselves to learn from each other, because we really have to increase our knowledge. And then we have a vaccines hub. We have a different financing models with private-public partnerships, venture capital things, all of this, because money is very tight. So we have to be innovative in order to convince those who hold the public purse that we spend it wisely and economically and efficiently, and also in a competitive way. We have new structures so as to, go through this valley of death and get the companies from there to there. So lots and lots of places. But are we better prepared? Yes, I would say, but we are certainly not there where we should be, neither at European level and certainly also not globally, because capabilities remain very uneven also in Europe. And we need long-term investment, which is not there. We need predictability. Companies will not invest in anything if they don't know there's a market afterwards. I'm saying that because we have also our German colleagues in the room, and we need also, obviously, support from the political level, from Germany as a big NATO player, for the big discussions that are awaiting us on what we call the financial framework for the next 5 years. Now, that brings me, why do I saying all of this? Because we want to strengthen our internal preparedness. And that is, in principle, the same as when I hear it from others. We want to go for sovereignty, we want to go for security. But for us, it's actually also to go for reliability. Because we are far from having this secured, all of this. We don't know whether next year or next 2 years we get the budget for that, whether the industry remains in Europe. Absolutely not sure. So our sovereignty, health sovereignty, is also fragile. And that's why we're looking at it and investing in it and coming up with so many new models in order to keep it. And it's therefore matching the narrative of sovereignty and security, which I hear everywhere, and which we need as well. Because when we have that, we are reliable also as a partner in a crisis. Then we are also reliable to pull with others in partnership forward. Because sovereignty cannot be a hollow word. It needs ownership. And ownership means also domestic financing and domestic, whatever you do, how much, how big, but you have to have ownership. You have to pitch in as well. And all of this you will see back in our Global Health Resilience Initiative, where we have various flagships where we start with detection, say, what do we as detection today, and how can we support early detection surveillance systems globally? That's why we go and work with the fund very much. A big believer in the hub in Berlin as an open source epidemic intelligence. We have spread out, and we continue to spread out this capacity building with other friends in the Commission and money, but also our own, very much on this pathogenomic sequencing, because exactly as you said, Minister, this is the starting point. We need to know, as it was in Cape Verde with the hantavirus, yes, it is the same strain, so it's not a mutation, or now in Kinshasa, where people would say, yes, that is the strain that we had not thought it would come. It is not Zaire and it's not Sudan. So it's Bunjibuya. But so this is where we want to go ahead, and we do the same with wastewater surveillance systems, the Glovacon, because we are a strong believer it should be very simple and it should be available, and then with the, of course, sovereignty of the states themselves to hold the data. Therefore, we are also investing in the Global Therapeutics Development Coalition. You have heard me, perhaps some have heard me in the beginning of the week, where we said we will support this, because we also go ourselves in the therapeutic hubs, because we know we have to go from diagnostics to therapeutics to vaccines and then procurement and stockpiling. We also have different hubs. We have a diagnostic and whatever hub, but we want to have a ecosystem, to use your word, that is integrated, because otherwise we have gaps. And that brings me automatically to finance. In order not to have gaps, you have to have financing throughout this pipeline. And it's very, very difficult for people to understand. Because if I speak to our budgetary authorities, they'd say, oh, but you have money for this. And I said, yeah, this is that part. But the beginning of the pipeline, I need a different type of budget, and I don't have it. And how can I deliver on the end if I don't have it at the beginning? And that is very difficult for all of us to get that momentum. But they will hold us accountable afterwards and say, why haven't you delivered? That's where you're there for, right? And financing means for us also a tracker of what is the financing used for, and where is the financing, and where are gaps. This is not a naming and shaming thing. It is not because, oh, you do more domestic or you do less domestic, but it's identifying where we have big gaps in our overall architecture, where then the money should be directed to. And that's why with the WHO, OECD and World Bank, we are building and helping this global health resilience tracker, because I think it is very important to hold everybody accountable, but also to go for areas where you have multiple benefits. And the same we could say we do on many, many other things. That brings me now to perhaps, again, the word of how do we act now together in this crisis for Ebola. We have many actors, all are good willing, everybody has different strengths and different, perhaps also weaknesses. So for me, very much WHO, but also then African CDC has to be working in a teamed up approach, very, very clear, according to their different strengths, but also us as then funders, as scientists, we have to pool, because that we don't have, as we would say in French, gaspillage. We have to make sure everything is interoperable and it reaches the people on the ground, which is not the easiest thing. DRC knows how to deal with Ebola. Uganda knows, but in the part where the government has not the control, not the access, they don't know it, and they clearly have not seen it. So we have to make sure that there the access is with the right medical countermeasures, with the right diagnostics, with the right mobile labs, but that all of this is coherent and that we are not, that we're really serving everybody. So that's very important. Let me say a few last words on the WHO. And I would like to say that very clearly and without any qualification, because this year the World Health Emergency Program has its 10 years anniversary. 10 years. It's a bit, we are only 5 years, you're 10 already. But a decade of building up, a decade of hard learning, I think a decade of investment into the global architecture, and somebody that you really grew stronger. And I think we all know that there's always something that they tell to me as well. HERA always has to improve. Yes, of course, everybody can improve. But in our Global Health Resilience Initiative, we made it very clear that the WHO, and with it the emergency program, is the partner in our logic on which the global health, the open health system should depend and rely on. And that's why also we made a very deliberate choice, a deliberate commitment. It's a strategic choice to say we want this system to be genuinely grounded in the WHO, which has to now also, of course, prove its worth. And we want a well-resourced and well-trusted WHO. I think that's very important. And that brings me back to what I said in the very beginning. We are now in a pivotal moment. We have a crisis which for some reminds us of the 2014 crisis. So we really have to now demonstrate that, yes, we were already better prepared because we know we had already certain responses, but now this might last for some time in DRC. So therefore, we have to really get that together to demonstrate that we are delivering, that the system is delivering, that multilateralism, cooperation is the right answer. Because to end, sorry, with what you said, you used the nature as a allegory. Actually, we are now in a moment where we have so much instability geopolitically. We have tightened budgets. But we also have climate change and we have biodiversity loss. So we have a surge, actually, of zoonotic diseases, smaller and bigger ones, right? So all of this is not easy for us all to stomach. So we have to now really come together and be acting in full partnership and trust, but also transparency. Thank you very much.
Thank Thank you so much to Dr. Fink Hoyer, and you really show your experience as the former DG Environment for the European Union as well. I wanted to pick up on one of the things that you emphasized, though, which is the importance of financing, or what we can think of as the flow of water going through the ecosystem. And when the water is drying up, of course, the ecosystem cannot continue to survive. Let me turn now to the rest of the program and also give you a quick overview of how we'll proceed. We have two panels of excellent speakers, and after each panel, we'll have time for Q&A, so I hope you'll be ready with your questions that you want to pose to our speakers. And then after the two panels, we'll have closing remarks from Tim Nguyen from WHO, and then we will invite you for another reception. We're going to feed you twice because, of course, we want to make sure there's enough fruit for everyone, as I said. So without further ado, let me invite our panelists to join us for the first panel. I'd like to invite Dr. Varoj Tangcharoenpatien. Everyone knows him as Dr. Varoj, Secretary-General of the International Health Policy Program of the Government of Thailand, and also the Vice Chair of the Intergovernmental Working Group of the WHO Pandemic Agreement. Next, we have Mr. Matthias Seike, who is head of the Division of Health Policy and Planning of the Federal Ministry of Economic Cooperation and Development of Germany. And last but not least, Dr. Maria van Kerkhoff, Director ad interim of the Department of Epidemic and Pandemic Management of the Health Emergencies Program of the WHO. Thank you so much for joining us. I'm going to stay standing, partly so that if somebody talks for a bit over their allotted time, I can begin inching towards you. I'm sure nobody will do that. What we wanted to do was indeed to have an interaction among the three of you and with our esteemed guests here in the room. So I'm going to begin, I think I'm going to begin, Maria Achi, with you, but then also Matthias and Varoj to respond indeed to each other, to your first comment. And I think one of the things we keep hearing over and over and over during this assembly is that the world has changed. We're in a very different context. You have had a frontline seat, I would say, not just a seat, you've been very active, certainly, in observing how international cooperation is functioning when it comes to dealing with outbreaks, including for medical countermeasures. So could you tell us, based on your experience, is it changing? Do you see this fragmentation showing up day to day in the work that you're doing, trying to help the world respond to these threats? And how would you describe and assess the most recent responses to the two crises that are on the table today?
So thank you very much, and thanks for the invitation to speak on the panel with my distinguished guests here. So, I mean, I think partnerships, certainly the landscape is changing. I think many have commented on this so far. Everything that we do is not only technically hard, but politically, with the geopolitics, with climate change, with everything that's happening, our work is becoming harder, and international cooperation is absolutely critical. We as WHO, represent all of you, but we never do anything alone. We don't want to do anything alone. It's the partnerships that enhance. I think I'm very grateful for all the speakers so far talking about MCM as not just vaccines. It's diagnostics, it's therapeutics, and it's that entire pipeline, to get this to the people that we serve. But the partnerships are what are key. We do have the international health regulations, which is incredible, and we've seen it demonstrated over and over again of how well it works when it does work. We saw this with the hantavirus outbreak, which, yes, is a contained situation of an outbreak on a ship, but involving 28 countries, involving multiple regions, involving many, many different sectors, where it worked, where people were communicating with each other, where diagnostics and sequencing happened in record time, where we knew from South Africa it was a hantavirus, where we knew it was the Andes strain, where there was collaboration with Institut Pasteur Dakar, who got on a plane and flew to Cabo Verde to support testing, and then from Switzerland, et cetera, et cetera. But it was the sharing of information and the working together to say, okay, and of course, this is a very different outbreak than what we're dealing with Ebola. We knew the denominator in this outbreak in the sense of everyone that was on the ship, anyone that got off, where they were going, but there was a collective goal. And I really haven't felt that since COVID. I have to say, this kind of total coming together to say, we each know what we need to do. And I agree with you. There are so many partners in this space. And I wouldn't say fragmentation. I mean, I could say fragmentation, but maybe let's say specialization. Let's formulate it in a more positive way. There's definitely duplication still. And I think that's why efforts like IMCM-NET, which is interim, while the member states continue to negotiate PABs, which will happen. I am confident that all of you will work incredibly hard to make that happen. And of course, we have PIP for flu. But the specialization in the different agencies, for us, we want to harness. It's not a threat, but it needs to be coordinated and it needs to be working in sync. Coming to the most recent outbreak of Ebola, of what we're seeing right now, yes, a public health emergency of international concern. Again, we're using IHR. This is a very different situation. And everyone has some PTSD from 2014, 2015, but we are not the same as we were in 2014 and 2015. We are not, and we shouldn't act that way. So we don't know the full extent of what's actually happening right now, but we are seeing people come together to say, okay, what do we need to do? How do we have a coordinated approach? Cannot be done here from Geneva, cannot be done from any of the capital cities. It needs to be done on the ground. And most importantly, serving, the people who are in insecure areas. Trust is a massive issue right now. Diagnostics is incredibly challenging, and we're supporting that with all of your help. And we will sort this out. We will sort out the diagnostics. I think on the therapeutic side, which is quite promising, vaccines are a little bit different, but with partners working together, I think I just want to emphasize how important that is. That will never go away. And your effort to work with us and your push of us, my phone is ringing, is I think what drives us all to do a little bit better. So international partnership, using IHR, working with us is absolutely critical.
Thanks so much. And I take note of the fact that you said, I could say fragmentation, but I'm going to say specialization, because I think that touches on this theme around the global architecture that we keep hearing about over and over and over again. This week, certainly, it's also a very important issue on the agenda about the question of, can these specialized actors work together as a functioning ecosystem? And what I'm hearing from you is yes, and quite a positive assessment of what's been happening, including as guided by the IHR. So Matthias, I want to actually ask you to react and respond. Do you agree with what you just heard from Maria about the current ecosystem, and in particular, given your role, I would be interested in hearing from you, is there enough water flowing into the ecosystem? And if we think about water, of course, that's financing. We know that official development assistance has been a key source of financing going into the MCM ecosystem, arguably the major source, and that source of water is drying up. Do you agree with Maria's assessment of the cooperation? How does that look when you look at it through the lens of financing?
Yes, thank you very much. Well, first of all, on the question of fragmentation or the number of actors in the field, I absolutely agree that in this field of the medical countermeasures, the expertise that is needed is so specific that there is very good justification that this is not done only by one organization, but that we also have some specialized organization, and that's why for us it was also very important to have the second panel after this one with those institutions coming in the dialogue and showing how the coordination together with the WHO is functioning. And what I also would like to add on a positive note, from my perspective, not only the hantavirus, but also some of the virus disease outbreaks last year in Africa were rather positive examples where it was possible to contain them very quickly, like, for example, the Marburg virus disease outbreaks in Rwanda and Ethiopia. So these were, at the beginning, very alarming news, but then it was possible to really contain them. And I think that shows us that in the last few years, there really was substantial progress in building up the systems at the country level. Then on your question on the funding streams, I think there's no way denying that resources are getting more scarce, and they will never be enough. And to be honest, coming back also to our colleague minister, honorable minister from Indonesia, on the question whether pandemic preparedness and response is a global public good. Yes, of course, it has this dimension, but I don't think if we frame it that way that this automatically solves all the issues when it comes to funding. In the end, it is always the taxpayers' money that has to be combined from countries all over the world. So even if we combine ODA, it's not with domestic resources. It's always all countries in the world that have to contribute their part, no matter whether you frame it as ODA or as global public good. I would like to make one more additional comment on the issue of fragmentation, and now not in the sense of the number of organizations, but more the political level of how much consensus do we have at the global level in working together on pandemic preparedness. And there I think we are really struggling at the moment a bit, not only a bit, because again, the pandemic fund as an example, the WHO is a very important partner in the pandemic fund, but it is also under huge threat. And there has been movements to push around and by some members, and that is something where we, as those countries supporting and working together with WHO, have to stand very firm to make sure that when we combine our resources, that we always also have the expertise of WHO on board. We really rely on it. Thank you.
Great, thanks so much. Dr. Feroz, let me turn to you and ask if you agree with what I think was some good news we heard both from Maria and from Matthias in terms of the health of the ecosystem today. And especially in light of your role as Vice Chair of the IGWIG, it would be very interesting, of course, to hear your views on whether do we need to wait until those processes are finished? Is there action that can happen, that is already happening, while that negotiation process reaches its conclusion?
I partly agree and partly disagree. Agree if the size of outbreak is small. If you have multi-regional major fake, the current mechanism is quite inadequate and not systematic. That we have to have a PA on board. And PA still not yet ratified. Upon pending negotiation and this WHA, we cannot adopt an annex as we wish. And it was extended to WHA next year or at the earliest December this year at WHA Special Session 3, if we are lucky. And if IGWIG membership has a strong intention to have it on board. And it takes time to ratify. Until 60 member states ratify, then it comes into force, and the COP1 trigger all the process. The inadequate is mostly on countermeasures and financing. At the scale of COVID, the current MCM net, current stockpiling just a peanut to fight Jack and the giant. As an analogy, the Jack cannot fight against the giant. Therefore, we need to rapidly adopt the annex. This morning, Mandarin was there. Ambassador Tova, myself, Matt from UK, and myself talk how we facilitate through co-facilitators to support the informal prior to the IGWIG 2 weeks negotiation in July. So that is my immediate response. We need a sustainable, systematic, adequate. And Article 12 is the key in terms of access to materials and sequence information, as well as sharing on equal footing. Just a quick response. Thank you.
Thank you so much. Matthias, Maria, what do you think? Do you agree, disagree?
I agree partly. I agree in terms of the importance of really getting to a good result for the PAPS negotiations. So, and I hope that all the negotiators, I'm not part of the group, will work hard on it. But to be honest, I wouldn't expect the PAPS mechanism to solve the full financing needs. So it will hopefully play a significant part, but there are other initiatives that are being worked on, like, for example, the G7 Search Financing Initiative, and we are in very close and concrete discussions together with the World Bank on putting into place a mechanism to mobilize day zero financing at a very large and substantial scale through the capital of the World Bank, which will enable us to be a lot quicker than having to go around to all the finance ministers to put grant funding on the table, and also being able to very substantive in terms of the volume of the funding.
Thanks so much, Maria.
So I will never disagree with Dr. Viraj. I have learned that. No, I've learned a great deal from him and everyone involved in the INB and the IWIG negotiations. I think the point for us right now is that we can't wait for it to be finished. We are confident it will be finished, it will be ratified, it will take some time and it will be difficult. But I'm very hopeful that it will, and there are many, many, many people who are working to make that happen. But as the World Health Organization, and for all of you, we can't wait until it's done. So that's why we have these interim mechanisms. We have a system for flu, which we've had since 2011, celebrating its 15th year. Not only is WHE, our Health Emergencies Program, celebrating 10, PIP is celebrating 15 years, and my goodness, are we lucky to have that system in place. Will it solve everything? No, but it's a framework that's agreed, that was blood, sweat, and tears negotiated, and we have access to hundreds of millions of doses of vaccines, we have therapeutics, we have syringes, secured for flu, but we had nothing else. We had no other system in place for anything else. And the world came together for COVID, and we learned from flu, but we put a system in place, but we weren't all ready for that. And we saw the inequitable use of diagnostics, therapeutics, and vaccines. And now we have the Interim Medical Countermeasures Network, which is supported by member states. Again, that's incredibly difficult, but it's a framework that's in place in the interim. That's on purpose, because we don't want to get ahead of member states, but we need something that's in place. We have the BioHub that's been set up to share pathogens outside of flu, and it's working, but it's piecemeal. And if I dare say it, and I'm sorry to my colleagues, it's a little scrappy, right? We've pulled it all together. There's incredible minds working together, and it is functioning, and it's functioning well. Could it function better? Absolutely. And that's where all the partnership coming is needed. I think on the financing, I'm not the right person to talk about financing, but we can spend billions of dollars a day on a war, and we don't have money for this. It's ridiculous. And we don't sell health the way we all believe that it needs to be sold. It's livelihoods, it's economies, it's all of that. So I'm very frustrated in the financial space because there's always money somewhere. And all of us with our tin cups begging for it, that is incredibly frustrating. So that's, again, where that partnership is important, where we have the pandemic fund, but where we come together and we're not competing for funds. Our specialized agencies and our collaboration around that use every single dollar or yen or euro or whatever to maximize it, and not just for one particular pathogen. So we just can't wait as an organization to fulfill our mandate of keeping the world safe.
Thanks so much. I want to give Dr. Roj a right of reply, but also give you a fair warning. I'm turning to you next for any questions or comments you have before we close out this.
The Ebola stockpiling is 500,000 doses stockpile here in Switzerland. And we dispatch within 7 days to the affected and used to ring fence around those affected population, to ring fence, keep them immune so that they will not spread over. But in an unlikely event that the Ebola spread quickly because international travel beyond neighboring countries in Sudan, DR Congo or Uganda, then it is a catastrophic that the stockpiling is inadequate. And bad news that the variant that caused the Ebola outbreak today, the existing vaccine, the two vaccine doesn't work. That is the bad news. Then I believe that member state, DR Congo, has shared the pathogen and sequence information already to all the biolabs. And the sequence and VTD will be produced without a clear, legally binding benefit sharing, because we don't have a PAP, we don't have PA today. So that is the risk. If in an unlikely event that is spread big, of course we have PIP. The next pandemic can be a flu pandemic, influenza with pathogenic flu, because flu is scattering around at our doorstep just here. Then we are not much prepared, but PIP is better performed. Now the IMCM net, I don't know the size of budget, but I think it can be quite small, very dim. So you are operate at a margin of risks, and we cannot take further risks. We cannot be complacent. Then we have, I don't know, Mandarin, you want to have it done by end of this year, not everything. Everyone want to have it done quickly, and we have a systematic approach. I agree with you on the financing, and I don't know, the G7, G6 plus scale up research financing, I doubt a lot whether we can ramp up big financing to support or not. But of course, domestic funding is the key in response in the pandemic.
Thank you so much. Let me turn to the floor, and we have time for maybe one or two quick interventions. So we'll see Els Turele right in the middle there. And then anybody else? Oh, up front. Oh, yes, sir. Madam Halton.
Thank you very much. My name is Els Torela. I'm an independent researcher on equitable access to medical countermeasures. And I think my question is probably to WHO. I read this morning that a trial is being started with two therapeutics against the new Ebola outbreak. Can you confirm that there have been binding commitments with the companies, because it's Gilead's drug and a MAP drug, a monoclonal antibody drug, that there are binding commitments in place that will ensure equitable, affordable access if the trial is successful?
Okay. Let me also then give the microphone up front to Madam Jane Halton, who's the chair of the board of SEPA. Please. Oh, you have the floor.
Thank you. And the former chair of the PIP negotiations. So something I know rather well. I just want to ask a question about the financing. So Viraj, you just said you don't think, well, I think somebody said that they didn't think all the financing details would be in the PABS annex, which I have to say I agree with, and I think to try and do so is a folly. But I just wanted to ask you to distinguish, if you might, in your remarks, between the surge you need at the beginning versus the longer-term response. So if you think about what we had to do during the pandemic, and for those who I don't know, I was co-chair of the COVAX coordination mechanism. We had a real problem at the very beginning, which was just getting enough capital to get things moving, as opposed to the financing inside countries. So I guess I'd be interested in the comments from the panel about how you think we could strike that balance, because we do need mechanisms to have the bank and others be able to move in really quickly, while others mobilise domestically or in other contexts. We were able, as CEPI, to mobilise our balance sheet right at the beginning. We had that flexibility, others did not. So could you just make a comment about and distinguish between those two things? Short-term surge, longer-term.
I have a quick response. I believe on conventional long-term capacity building. If you look at IHR core capacity through SPA or JE, focus on the low capacity country, build up their capacity and surveillance, detect, and health system capacity to detect. That will prevent a long term. And the outbreak, the spread will come from low income country with less capacity then the priority should go to our lower and low income country. Less so on surge capacity when the unlikely event of big fake. We need external funding. We need the visual coordination. We need effective. I don't think the PAP's monetary contribution is adequate to do anything, because unless we look at multi-billion mRNA vaccine, that we can mobilize funding from that vaccine sales. But we don't have that big event. Then all time during the inter-pandemic phase, we should have some very small. I believe that the monetary contribution or annual monetary contribution will be very, very small. So surge capacity require additional outside funding.
Yeah, so I mean, I can't guarantee anything right now as it relates to Ebola. What I can say is that our R&D blueprint is speaking with researchers, looking at different protocols, looking at what clinical trials could actually be put in place. There's a technical advisory group that's looking at the different therapeutics of what could be prioritized, what is the most promising. And I can tell you that there's a lot of work that will be happening in the countries themselves, with the PIs in the countries, with their permission, with their leadership, on anything that is actually done, getting ready. So whether we're talking about a therapeutic or we're talking about a vaccine, to actually be ready when that green light goes. And I missed the press conference because we were here. So, and we're speaking directly with Vasi Morty. He's our new head of R&D blueprint at WHO. So if anyone wants more specifics, I advise you to get in touch with him. But on the financing, if I could just very, very quickly say, I agree with Dr. Viraj here, but the financing that we need at the start of an outbreak, at the start of pandemic, comes from our contingency fund for emergencies, which is dangerously low right now. This is what actually gets money out the door within hours to actually scale up surveillance, contact tracing. You're not going to have any use of these diagnostics, therapeutics, and vaccines if you don't have good surveillance, if you don't have good community protection working with communities. Those funds that we have rely on donations from countries, and so many countries have been incredible, but right now it is dangerously low. And that's where we need that funding to start, as well as what we need for actual production and actual distribution and implementation.
Thanks. Last word, Matthias.
Yes, I agree on the WHO funding, of course, but coming back to the World Bank mechanism and how it would work also in terms of timing. So I see the great potential in this very short period of time within the first few weeks when it comes to also development of vaccines and therapeutics to have funding through the World Bank balance sheet to agree on advance purchase agreements. I think that could be the great benefit of it. But then you are right, when you go further along in the coming months of a pandemic, then you need additional funding and also grant funding to finance the distribution for those countries that cannot afford it from their own budgets.
Thank you. We've covered a lot of ground. I've taken up too much time, so please just join me in thanking our speakers. I'd like to hand over to the moderator of the next panel, my colleague Daniela Moric. I also just wanted to suggest we might spend a few minutes going over time, and we are bribing you with good food after the event. So I hope we might take enough time indeed to hear from our second panel, as well as from all of you during the Q&A.
Okay, welcome to panel number 2. My name is Daniela Moric. I have the great pleasure of moderating this discussion. And as we don't really have a lot of time, I'll go straight to introduce our panelists, starting on my left side, Jeanette Ginard, who is the Director for Strategy at Unitate, followed by Jutta Reiner-Rapp, Interim CEO and Chief Scientific Officer at Find Diagnostics for All. And last but not least, Aurélia Nguyen, Deputy CEO of CEPI, the Coalition for Epidemic Preparedness Innovations. So let me start maybe with Janet and pick up on the coordination that we just discussed also in the previous panel. So we have seen this declining financing. We are seeing shifting political priorities and also growing competition for resources. So from UNITAID perspective, how do you preserve coordination in this environment? I was going to use fragmentation, but we decided we're not going to talk about fragmentation, but how do you announce this specialization and actors working together?
Sure, thank you very much, and thanks for the organizers for having us here. It's really a pleasure, great question. I think in the current context of constrained resources, collaboration, trying to figure out the complementarities is more important than ever. I don't think there's an easy answer to the financing question and the fragmentation, but I do admire and value the reframing that we heard from Maria, from Minister Budi this earlier today, to say these are not intractable problems. Right? I think if we can identify where the financing is most needed, identify the roles that each organization can play, the assets that each can bring, and to do that in a way that is dedicated to identifying, addressing priorities, and being able to bring the value of each organization to bear, then I think there's more that we can do. I do think that it's unavoidable to acknowledge that we have seen a chronic underinvestment in R&D for therapeutics for many, many years. So the pipelines do need attention. Early R&D, discovery, preclinical work is more important than ever. We can talk about access being programmed in very early. Appreciate Elle's question, thank you, and other champions for early access design. But we can't magic up access on a product that doesn't exist, right? So I think that attention to early R&D pipelines, replenishing those pipelines, the financing that needs to go there, and then identifying the collaboration that can happen across many different organizations is really key. So as UNITAID, it's one of the things that we've tried to articulate with partners who've been involved in the Therapeutics Development Coalition, so the International Pandemic Preparedness Secretariat, many other partners, UNITAID, DNDi, MPP, who announced earlier this week, good news on flu, and Ready, Intrepid Alliance, and many others. So really acknowledging that there can be a coalition of the willing coming together and pooling resources, pooling their capacity, and being able to approach this with a coalition type approach.
Excellent, thank you. So it is possible. Jutta, maybe I'll move to you, and feel free to react to what you have just heard. And maybe I can also add something. Well, diagnostics, sometimes they receive a lower level of attention as compared to vaccine and therapeutics. What do you see this balance stand today? How do you see things changing?
Slowly changing, and if I may say something about FIND, we are uniquely positioned in this diagnostic space, so you will hear me advocating for diagnostics. But I have to say, when I joined and listened to the speakers and panel before, I was really glad to hear that there is really the approach of an integrated approach. We need diagnostics very clearly. It doesn't work. The detection in Ebola, in this outbreak, was a big issue on the diagnostic side. I think we are running late because we did not diagnose correctly this strain. So from a FIND perspective, we are uniquely positioned. We bring expertise from COVID, but when I look back into COVID times, I would say we were a bit on a reactive mode, which really changed since then. Are we fully prepared? Probably not. But I think we are bringing together partners, and I like this specialities. We bring them together much better. And FIND is part of many conversations at the moment, and we prepared internally now with an internal task force and a framework that we have to address the diagnostics gap.
Excellent. Thank you very much. Moving on to CEPI. Aurelia, there is obviously, growing emphasis on early access conditions in the R&D, in the early phase, instead of addressing them during the crisis. Do you think that this ambition is a reality today?
Well, thank you very much to the organizers, the Graduate Institute and WHO, but I can't also be at a panel that is organized by the government of Germany and EC HERA without appreciating their contributions that have just been made to CEPI, to our new strategy, because Germany was the first investor to come in for our new CEPI 3.0 strategy. And yesterday, EC with HERA, Florica announced being our latest investor to come in. So thank you very much to Germany, to EC, for your support to CEPI and for hosting this discussion, and I think showing the leadership in this area. I was thinking about what Janet and Jutta was just saying, and thinking about how we look at the coordination, specialization, fragmentation, call it what you will. And I think there's been a lot of progress. I could talk to you about joint coordinating groups and funders roundtable, etc. But I think this Ebola Bundibunjo context, I think, is really the sharp end of the spear. So let me maybe talk about it in terms of R&D and vaccine development specifically here, and starting very much from the country level. So we have the benefit of having countries who do have experience with epidemic outbreaks when it comes to DRC, when it comes to Uganda. I think we're all holding our breath a little bit from the side of South Sudan, but very much having the country at the core. Given the context, of course, Africa CDC will be very important. And then comes the role of WHO. I was just pestering my WHO colleagues about the technical advisory group to talk about vaccine selection, because it is absolutely fundamental that product selection, whether it's a therapeutic or vaccine or a diagnostic, is being done in an independent manner. It is not for us as implementers, funders, and partners to be choosing products. That really has to be done through an independent, rigorous mechanism. And then CEPI can step in and do the work that we do. And actually our new strategy really, I think, is very well mapped to the outbreak that we're seeing unfold. Because from the first perspective, there's the question of how do we think about the pathogens that emerge from which viral family? We didn't expect Bundibunjo. The last outbreak was in 2012. There were 13 fatalities. We're less than a week into the declaration of the fake. We've already got 10 times that amount of fatalities. And so actually, it just shows that we can think about the known pathogens, but actually, if you don't take the whole viral family as a whole, then you're going to be missing some really important parts. And that's the first part of the strategy that we're doing. And also thinking about, are we developing, I think it was Florica who mentioned interoperability. We've actually funded at Uganda UVIR the development of an antibody assay, which using serum from previous Bundibunjo survivors, so that everyone is developing vaccines to a common standard. The second part of our strategy is around platforms and vaccine platforms. So here we're looking at candidates. Is it going to be a VSV or a ChAdOx vaccine? Is it going to be an mRNA? We don't have a perfect vaccine platform. We probably need to be looking at all of these in parallel or in conjunction with each other. And the third part of our strategy that comes in is around networks. How do we have the strength of clinical trial networks? Do they have the right biosecurity levels to be dealing with these pathogens? And so it all comes together, and so that everybody in coordination, and I think being very clear on who does what, can do the best science in a very difficult, we heard it, very chaotic setting. And then downstream actors can come and play their part Gavi with the First Response Fund, the Corks led by ANRS in France, who can look at research questions, and it all comes together. Maybe the last thing that I'll say is, I mean, I want to agree wholeheartedly. I think we're in a very different position than we were 10 years ago. Some bad in the sense of 10 years ago, we did have a phase 1 clinical candidate. Today, it's much more confused. I want to comment on the gender representation on panels has evolved. So I don't know, there's a manel equivalent. Are we a fanel? But I think we have much more clarity. We have much more sophistication. I think we really need to push on data. We are struggling not only to get our hands on the data, but to get a single source of truth. So I think there's a lot to be done. Enough has been said about financing. The last point I will say is governance. Each institution has their own governance that we need to respect, but it needs to come together.
Thank you very much. A very complex ecosystem where everybody needs to come together. I'm conscious of the time. I would like to ask a question to each of you. If you can think about what is the single most important action that needs to be taken to improve and strengthen the functioning of this ecosystem. And then I'll open up for a question from the floor. So please be ready with your hands up. Janet. We start for you, maybe.
Sure, thank you. I spoke a little bit about the chronic underinvestment in R&D, and I think enough has been said about the lack or the need for financing. But I also want to make a point on the sustainability, the predictability, and the coordination of the financing. And it's maybe building on the point from Aurelia on the dynamism of the contexts that we need to navigate. Navigating an uncertain or evolving context is going to require data. It's going to require reevaluation of strategies, and it's going to require revisiting and maybe evolving some of the strategies for medical countermeasures and acknowledging the interdependencies between them. And we've talked before about the kind of the interplay. If you have a therapeutic that has effectively a preventive use case or a vaccine that might be effectively therapeutic, what do you do with that? How do you build that into the strategies for how those tools can be deployed? So I think really thinking about how to navigate dynamism, how to bring data and evidence on what tools are available, emerging tools as they become available, what's needed to understand the use case, and then optimize the deployment. But it all comes back to lending some predictability and coordination to the funding requirements for what it's going to take to roll out products if they are available. Thanks.
Predictability. Thank you very much. Jutta?
Thank you. I'm not talking about financing. I think from the action side, when there is an announcement of an outbreak, there's a lot of action happening. You know, we all get together. Everybody tries to contribute as best as we can. What I wanted to point out is the time before the outbreak. You know, we need to keep going to be prepared. And I love sports, so for me, we have a marathon before, and we need to be resilient and sustainable in this marathon, because when we have the outbreak, we get into sprint mode and we run fast and much better coordinated. But for me, the action is really, hopefully we get over this outbreak and we contain it quickly. But everybody knows it's not the last one. We will have more. We need to keep all the systems, the manufacturing, the R&D, we need to keep going, and that's a very, very difficult sell to the financial. So now I'm coming to the finances, to the financial world. Thank you.
Thank you. Aurelia?
I think I might surprise even myself to say, yes, I mean, financing, the coordination, etc. But I also reflected on the point Florica was making, which is there's a lot that we still need to solve on the science. And we also need to think about this. You were talking about the different budgets and where they come from. The science is still extremely difficult. And I think we cannot underestimate the amount of effort and investment that is required when we think about the threat space that is very, very large across all of the different viral families. And I don't think, had been focusing very much on the hantavirus family. All of a sudden, to Juta's point, we're having a little bit of a scrambled. I just mentioned earlier on in terms of within the filovirus family, Bundibugyo was a little bit the sort of lesser cousin, so to speak. And I think understanding the fundamental landscape, understanding what the immune markers are, what the mechanisms are, is still really something that requires a tremendous effort. And then beyond that, in terms of the technology, we've made fantastic progress, but we don't have a silver bullet platform. So we have mRNA, fantastic for rapid response, but it has ultra cold chain requirements, which in this setting is going to be extremely difficult. We have VSV that produces very safe, very efficacious vaccines, but the CMC on the manufacturing is a complete nightmare. And so we still need to be progressing across all of these different elements. I think this is where here artificial intelligence will play an important role in terms of modeling, in terms of knowing where threats may emerge from, in terms of doing rapid vaccine design, in terms of being able to do clinical trials with much fewer patients, and the like. And this is something that for CEPI we've been investing in. We have a signature initiative in our new strategy called the Pandemic Preparedness Engine that will really look at the AI-enabled capacities for vaccine development across the whole chain. But I think these are still something that sometimes we take for granted because we've come really far, but there are still huge hurdles to be done. And once the science is there, it's also around the communication and around the trust in the science that we need to nurture. And we know that we're really facing very strong headwinds there too.
Thank you very much for reminding us of these difficulties. I would like now to open the floor for questions from the audience. I can see, okay, one up here on this side, and then we're going to take the other side. Thank you. If you can introduce yourself. And we're going to
Thanks. I'm Michelle Charles from DNDi, and greetings to my sister organisations. Just to say, and I think linked to the title and both of the panels, is that we understand that financing is an issue, and we agree with Janet that there's a question of where you direct that financing, and there is an issue that we need to focus on developing the tools that we have access to. But I think it is helpful to also look at Article 9.5 in the Pandemic Agreement, which specifically said that when you are putting public financing into research and development, you should put conditions to ensure access. And I think that that helps all of our organisations, that when we are working with other organisations, public or private, who have received public funding, that it helps us to try to put in place those conditions that Els was talking about, so that we not only develop the tools that are needed, but we can ensure that they're accessible to the people who need them.
Thank you very much. We're going to take a second question. And, yeah. Oh, sorry, here.
Thank you very much. Veronica Denti. I just ran a research funded by Gates Foundation at University of Geneva on vaccine demand. And I know this panel is more looking at the technical and the financial challenges to get from vaccine to vaccination, but I'd like to hear a perspective on the last channel in the pipeline of adoption, which is the one of trust, on the behavioral barriers of having the public trusting your very institutions with the science under speed. What do you see the role of building that trust is?
Thank you very much. Maybe we start with Janet. Do you want to react to Michelle's comment? And Aurelia on the next one.
Sure, I can be brief. I just want to acknowledge the importance of that access question that Michelle raised. I think equally recognizing that if we have more than half of WHO's priority viral families that lack phase 2 ready candidates, really appreciate DNDi's focus on establishing and encouraging and fostering resilient, geographically diverse R&D networks. and being a champion, a sister champion for access. As Unitaid, we run a strategic initiative on access, and we are trying to examine where we've had success in calling for access conditions early as a funder, how to make those durable across funders that might act at different points in the value chain, and to do that in a way that's collaborative, sometimes with industry and not necessarily antagonistic. So we recently convened a group of academic institutions in Washington, D.C. To share some of the insights from this community of practice and say, these are some of the opportunities that we have all along the value chain to design access in. So really appreciate that that's a growing, that seems to be getting traction, seems to be growing interest and a growing audience interested in some of these issues. And that combined with the attention for additional work earlier is really appreciated. So again, appreciating the leadership of WHO in calling out where some of the gaps are, and the EC in calling for attention and focused financing for this. Thank you.
Thank you.
Absolutely, absolutely.
If I may, I spent more than 20 years in the pharmaceutical industry, and I don't know how many people are here from the private sector. But it might be a surprise that in whatever project we did in our company, from the very beginning, after preclinical, when you enter into clinical development, you have a fully integrated development plan, and you have an access part in that. And this is absolutely about equitable access. You may say, okay, is that true for each and everything? But on the projects I was working on, it was in the global health space on neglected tropical diseases. There was a very clear access paragraph. And I think it's sometimes a bit neglected. Please look also what IFPMA says about it. I think it changed over the past decade. There's definitely a shift also from an industry side on the access.
Thank you. And if I can maybe build on that also as an ex-manufacturer, I mean, I think in the end of the day, until you have something in contract, you don't have access. And I think the reason, Michelle, to your point, that I think we're all looking at Article 9.5 is that that will help affect that contractual mechanism in a way that will get all boats to rise with the tide, so to speak. But to the earlier point that Maria was making, in the interim, we need to be doing that one by one and making sure those access provisions are built in. And so at CEPI, we signed a contract with Moderna on their phase 3 candidate for H5N1. And that was very much with access in mind, in exchange for de-risking their phase 3 trial. They have guaranteed 20% of volumes in the eventuality of a pandemic on H5N1. And those are the types of contractual commitments that we want to be able to see. It's being done also in a way that looks at being geographically dispersed. That's the other thing that I'm surprised hasn't come up in conversation yet, in terms of having geographic resilience and having manufacturing capabilities spread out across different continents and different sites. And then, Veronica, to your question around trust, one of the things that from an R&D perspective is really important is starting the R&D as early as possible within the context of the communities that are affected. So I'll give the example of the Lassa Fever Coalition, which is headed by the ministers of health of Lassa endemic countries in West Africa, led by Minister Pate, along with the other affected countries. And I think having that country ownership right from the start around the recognition of the need and having the clinical trials being done in country as quickly as possible, and then moving onwards to having vaccine production being done. So in this instance, it would likely be Institut Pasteur Dakar. I think that over time will complement and will add to all of the other parts that, of course, are going to be fundamental around community, communication, engagement, and the like. But I think it really has to start right from the beginning of R&D.
Thank you very much. I think we are a bit over time, and I know we are bribing you with additional food, but I think I need now to close also panel 2. Please join me for a round of applause for our panelists. Thank you. And I'll give the floor to Ting Nguyen for closing remarks.
All right, I'm standing away of food, so don't want to be the target any further and let you off. But so we'll be very brief, in the closing remark. First, thank, of course, our 2 keynote speakers, our 6 amazing panelists, and of course our 2 moderators. So thank you very much for making this so eventful and also interactive with the audience. I think we heard a wide area of input, and we have enough food for thought for now. But let me maybe summarize 3 takeaways that I heard from the discussions today. I think the first one is we do not start from zero, but we must act now. While we're waiting for the PUBs, hopefully, to finish today or later by next year, and then awaiting the pandemic agreement to be ratified, we cannot wait for it. Equity doesn't stop there. And we have some tools already at hand. We have the IHR amendments that allow us to have some set of rules to enact, but we do have strong multilateral engagement already, and we need to build on this, what is already existing, and build on this collaboration. So the challenge is not only the absence of rules, but how effectively we can use it. And political will, trust, and early cooperation are as important as legal frameworks. I think the second takeaway was that equity depends on coordination across a specialized ecosystem. I think we adopted a new framing around this. So we do not lack initiatives, but we lack some alignment around this. And I think that's something where we can work on across this entire ecosystem we've been describing, from R&D, from manufacturing, procurement, allocation, and delivery. And delivery includes the trust with the communities that we must be integrated in our work. So also a more coherent approach to funding. We heard, that is a major theme around this, but that the PUBs will not alone resolve the funding issue. So thank you, Matthias, also for highlighting the other parallel work that is existing. But the coordination around this is important, that we as a health sector go beyond running around with the tin cup compared to other sectors. So thank you, Maria, for this picture that you're creating in our mind, so that these innovations not only reach the patients affected, but the entire populations. And the third key measure is what we need: a platform that brings this all together. So we heard importance of WHO as a convener and a coordinator of that, and IMCMNet as an inter-mechanism can play an important role to bring these actors together. And we're already doing this, and I think, needless to say that, with this Ebola situation, we bring the partners together to discuss, this entire ecosystem and who brings what to the table to contribute to this. So with that, looking ahead, we should not wait for the perfect system to come in, but we need to do something now and focus on making the current systems and partnership and coordination work better together. So let me really close with thanking also the Graduate Institute, Sururi and Daniela, for hosting us, bringing this all together. Special thanks to Germany and HERA for actually paying for the receptions. So, I don't think you get in any kind of event 2 receptions. So here you get 2 receptions. I'm of course biased as a co-organizer that this is one of the better events I've seen so far during the WHA. So thank you. But I think in closing, I want to pick up the words of Minister Budi. I think he said during a pandemic, we cannot play God in deciding who gets countermeasures, but we need to make this a public good. So I think let's work all together to make this a public good. Thank you. Please go to the reception.